Yeah, so from the CLL13 GAIA study, there are two abstracts being presented here. This was a very large study including 926 patients, and we had 4 different study arms. The standard arm was consisting of chemoimmunotherapy with FCR or BR according to the patient's age. And there were 2 comparisons because we had 2 co-primary endpoints. The first co-primary endpoint was MRD, which was met with respect to undetectable MRD after 15 months, venetoclax-obinutuzumab versus chemoimmunotherapy. The second one was the triple combination, venetoclax-obinutuzumab plus ibrutinib versus chemoimmunotherapy with respect to PFS, which was also met. And now Eugen Tausch from Ulm as well as Moritz Fürstenau from Cologne, they showed in their separate presentations the role of different genetic factors and on those 4 different treatments. So first of all, Eugen Tausch, focusing on the molecular genetics, showed what we knew already, that patients with unmutated IGVH status, in spite of excellent response rates with respect to undetectable MRD, which were not different from those patients with mutated IGVH status, but patients with an unmutated IGVH status had a shorter progression-free survival with all 4 venetoclax-based treatment arms. The 4th arm was venetoclax plus rituximab, to add that. They also looked at some single mutations, and they found, which is quite interesting, that Notch1 as well as different RAS mutations, they also seem to have an inferior outcome in patients treated with venetoclax-based treatments, and this was also confirmed in a multivariate analysis for the patients. He also showed that in the past, classical poor characteristic factors as 11q deletion are not anymore poor prognostic factors, particularly not with the venetoclax-based treatments. Moritz Fürstenau looked at complex karyotype. We have learned that complex karyotype defined as 3 or more, or even as high complex karyotype 5 or more aberrations and chromosomes, that they are associated with chemoimmunotherapy, with poor prognosis. We knew that before, but now interestingly, he shows on the data of the CLL13 GAIA study that venetoclax-based treatments, patients have also a poor prognosis when they have a high complex karyotype, meaning 5 or more complex aberrations. The study is interesting because patients with a TP53 mutation, which is frequently associated with complex karyotype, were excluded from that study. So we have here really patients only carrying complex karyotype, and so the study clearly shows that this is another group of patients where venetoclax-based combination therapies, at least with venetoclax plus CD20 antibody, may not be enough in order to treat these patients on a long run very efficiently.